Hi everybody, I have chapter 24, Hematologic and Immunologic Dysfunction. It is a really dense chapter, so I'm going to go ahead and get started. To assess hematologic dysfunction, we first need to do a complete blood count. As a nurse, it is important to know the normal values of this. So here's a chart directly from the book to begin to get yourself familiar with it. In addition, we need to do a physical exam. This will help assess for the hematologic dysfunction, asking the child's energy about their food, um, diary, and any poor sources of iron, frequent infections, bleeding that can be difficult to control. And then when doing the skin assessment, assessing for pallor, petechiae, and bruising. The first red blood cell disorder is anemia. This is a decreased red blood cell or hemoglobin concentration for age. The classification is etiology or physiology and morphology. The etiology and physiology can show us the cause of the anemia, and the morphology will show us the size, shape, or color and can help with laboratory evaluation. The consequences of anemia include decreased oxygen available to the cells due to the decrease in oxygen carrying capacities. Cardiac failure can occur, growth retardation, anorexia, and delayed sexual maturation in older children. For diagnostic evaluation and therapeutic management, a physical exam is needed. Evaluation of CBC for decreased red blood cells and hematocrit levels. Other tests can also be performed, but they're usually related to a specific disorder. For therapeutic management, the objective is to reverse the anemia by treating the underlying issue. For example, if you have an acute hemorrhage, a red blood cell transfusion can be given, or for severe anemia, you can include oxygen therapy, bed rest, and IV fluid replacement. For nursing care management, it is important to consider the age. This can give you the etiology, racial or ethnic backgrounds, any special emphasis, stool examination, decreased tissue oxygenation needs. You want to assess the child's energy levels and create a baseline. Prevent complications by prevention of infection and observe for infection. Check for elevated white blood cells that can occur in patients with anemia without presence of infection. You then want to prepare the child and family for these tests, explaining the tests and procedures. Although these procedures are normal for us, they are pretty invasive procedures and they're not normal for the patient or the family. So, encouraging support for the child and their family, also allowing the child to play and participate during the tests, and allowing older children to participate so that they can start learning their diseases, especially if it's long term. Iron deficiency anemia is caused by inadequate supply of iron in the diet. It is the most prevalent and preventable in the United States and globally, and it is caused by inadequate supply of dietary iron. The most people at risk are preterm babies, children between 12 to 36 months, and adolescents. Um, Preterm babies, because in the third trimester is when iron is transferred to the baby. For children 12 to 36 months, it's because they drink a lot of cow milk and maybe they don't have the proper foods that are iron rich. And for adolescents, it can be poor eating habits, menses, obesity, and growth rate. Therapeutic management and prognosis, increased amount of supplemental iron in diet, stool analysis, supplements, parenteral IV or IM iron administration if child has malabsorption to iron, and transfusion in more severe cases. The prognosis is good, but in severe cases it can cause long-standing cognitive, behavioral, motor impairment, and even death. For nursing care management, you want to instruct patients of iron administration. Adequate dosage of iron can turn stools tarry green, so ensuring that they know that. Emphasis on follow-up visits. Ensure to address any non-compliance. Only a month's supply is stored. It can be stored at home because if you take too much, it can be toxic or fatal. If using iron dextran, educate patient on how to administer that, and then diet education. Sickle cell anemia is one of a group of diseases collectively termed hemoglobinopathies, where normal adult hemoglobin is partially or completely replaced by abnormal sickle hemoglobin. The term sickle cell disease is sometimes used to describe sickle cell anemia, but this use is incorrect. The correct term for sickle cell anemia are homozygous sickle cell disease and homozygous SCD. Sickle cell disease refers to a group of hereditary disorders that all have the presence of HBS. The most common form of SCD in the United States is sickle cell anemia. Sickle cell disease, which is a heterozygous variant of sickle cell disease that has both HGBS and HGBC, where lysine is substituted for a glutamic acid at the sixth position of the beta chain. Sickle thalassemia disease is a combination of sickle cell traits and B beta thalassemia trait. In the beta plus form, some normal HbA can be produced in the beta 0 form. There is no ability to produce HbA, and then sickle cell trait is a heterozygous person who have both normal HbA and abnormal HbS. Pathophysiology: obstruction caused by sickled red blood cells with other cells. Vaso-occlusion is caused by the abnormal adhesions of enlargement of sickle-shaped cells blocking the microcirculation shown in figure 24.3. And local hypoxia is caused by absence of blood flow and resulting in tissue ischemia and infarction shown in figure 24.2. Clinical manifestation: acute symptoms of the disease occurs in periods of exacerbation called crises. There is vaso-occlusive crisis. This is the painful episode, can last from minutes to days or longer. The sequestrian crisis: this is a pooling of large amount of blood that is usually in the spleen and sometimes in the liver and can lead to shock. Aplastic crisis is a diminished red blood cell production that can be caused by an infection. Hyperhemolytic crisis is an accelerated rate of red blood cell destruction characterized by anemia, reticulocytosis, and jaundice. Acute chest syndrome is the presence of new pulmonary infiltrate, and cerebrovascular accident is sickle cells can block major blood vessels in the brain, causing cerebral infarction, which causes a neurologic impairment. Diagnostic evaluation and therapeutic management. Newborn screening is extremely important. Acute respiratory tract infection and GI infection can trigger recognition of the disease in toddlers. Sickle turbidity test, and then also a hemoglobin electrophoresis test. For therapeutic management, we want to prevent sickling phenomena, treat medical emergencies of sickle cell crisis, provide rest to improve oxygen use, analgesia for pain, pain management, transcranial Doppler to monitor intracranial vascular flow, blood replacement, transfusions of red blood cells, and antibiotics. Nursing care includes family education, seeking early interventions, antibiotics, recognition of signs and symptoms, treating the child normally, emphasis on hydration, education on enuresis, pain management, monitoring for transfusion reactions, for splenomegaly, vital signs for shock, and record inputs and outputs. The prognosis can vary. Can happen by infection. Potentially terminal outcome for SCA. Hydroxyurea can have a 40% reduction of mortality, and allogenic hematopoietic stem cell transplant offers 92 to 95% survival rate. Beta thalassemia. Beta thalassemia is a common genetic disorder applying to a variety of inherited blood disorders characterized by deficiencies in the rate of production of specific global chains in hemoglobin. There are four forms. Two are heterozygous forms. Thalassemia minor is asymptomatic and a silent character, and thalassemia trait, it produces a mild microcritic anemia. Thalassemia intermedia involves either homozygous or heterozygous abnormalities, and a homozygous form, which is thalassemia major, results in severe anemia that leads to cardiac failure and death in early childhood. Pathophysiology. Pathophysiology: defective hemoglobin formation causing an unbalanced polypeptide unit that is unstable, that when it disintegrates, it damages red blood cells, causing severe anemia. In order to compensate, an overabundance of erythrocytes is formed. Excess iron from packed red blood cells transfusion and rapid destructions of defective cells are stored in various organs. Diagnostic evaluation and therapeutic management. It may not be recognized until late infancy or early toddlerhood. Signs of anemia and progressive anemia can occur. Bone changes can also occur in older children. For therapeutic management, we want to maintain sufficient hemoglobin levels, transfusions, prevention of iron overload, and splenectomy for children with severe splenomegaly. For nursing care management, we want to promote compliance with chelation therapy and transfusion, ensure the child is coping well, foster the child's family to adjust to a chronic illness, observe for blood transfusions for complications, educate family, and get genetic counseling for them. And then the prognosis for most children who are on early chelation therapy and are treated with blood transfusions survive well into adulthood. Most common cause of death are heart disease, post-splenectomy, sepsis, and multiple organ failure due to the hemochromatosis. Aplastic anemia is a rare life-threatening disorder that can be treated in 90% of patients. It refers to bone marrow failure condition where the formed elements of the bone are simultaneously depressed. The diagnosis of the condition must have profound anemia, leukopenia, and thrombocytopenia present. Hypoplastic anemia is profound depression of red blood cells, but normally or slightly decreased white blood cells and platelets. The etiology of aplastic anemia can be congenital or acquired. It is most likely linked to Fanconi syndrome, a rare hereditary disorder that causes pancytopenia, hypoplasia of the bone marrow, and patchy brown discoloration of the skin. Most AA etiology factors are idiopathic. Diagnostic evaluation and therapeutic management. The onset includes anemia, leukopenia, and decreased platelet counts. Diagnosis is determined by bone marrow examination. Severe AA is based on Comita's criteria. Moderate AA is more than 25% bone marrow cellularity with mild or moderate cytopenia. Therapeutic management includes immunosuppressive therapy, replacement of bone marrow through transplantation, anti-lymphocyte globulin or anti-thymocyte globulin, and hematopoietic stem cell transplant. Nursing care management includes preparing the child and family for diagnostic and therapeutic procedures, preventing complications, providing emotional support, and ensuring the family is aware of their specific treatment plan. Defects in hemostasis. Hemostasis is the process that stops bleeding when a blood vessel is injured using three factors: vascular influence, platelet role, and clotting factors. Hemophilia is a group of bleeding disorders resulting from congenital deficiencies or absence of coagulation factors or proteins. The two most common forms of X-linked recessive disorders are factor VIII deficiency and factor IX. Von Willebrand disease is another hereditary disorder that is caused by abnormality, deficiency, and absence of the protein called von Willebrand factor, and the pathophysiology is the basic defect of hemophilia A is deficiency of factor VIII. This is produced by the liver and is necessary for blood clotting. The less factor VIII in the blood, the more severe the disease is. Diagnostic evaluation and therapeutic management, history of bleeding episodes, evidence of X-linked inheritance, laboratory findings, and DNA testing. Therapeutic management is replacement of missing clotting factors using factor VIII concentration, using a synthetic form of vasopressins, corticosteroids, pain control, oral administration of Amicar to prevent clot destruction. Physical activity is reduced. Children are treated at home and are taught to administer anti-hemophilic factor for self-administration at the ages of 8 through 12. For nursing care management, we want to recognize the bleeding episode, be alert when the child with hemophilia shows signs of headache, slurred speech, loss of consciousness, and black tarry stools, assess for excessive bruising, assess for spontaneous hematuria, prevent bleeding, recognize and control bleeding, prevent crippling effects of bleeding, support family, and the prognosis is there is no cure for hemophilia, we can only control it. Children live with minimal or no joint damage, they have an average life expectancy. Immune thrombocytopenia is an acquired hemorrhagic disorder that is characterized by thrombocytopenia, minimal absence of bleeding, and normal bone marrow with normal or increased numbers of eosinophils and immature platelets. It occurs in two forms: acute, self-limiting, and chronic condition. Diagnosis, evaluation, and therapeutic management. Blood test. No definitive test is established. It is based on clinical manifestations, and other tests may be used to rule out thrombocytopenia. Therapeutic management includes support, restriction of activities, treatment of acute presentation, use of anti-D antibodies and IVIG to alleviate need for bone marrow exam, and splenectomy for children with long-term remission. For nursing care management, we want to give support, teach the side effects of therapy, limit activities when platelet count is low, avoid sports to prevent injuries, and educate on when to seek medical help. The prognosis is majority of children have no major complications as long as they are self-limiting. Others may have chronic ITP and may need therapy. Having a splenectomy can cause the child to be asymptomatic and modify the disease process. Disseminated intravascular coagulation is also known as a consumption coagulation. Is characterized by diffuse fibrin deposition in the microvasculature, consumption of coagulation factors, and endogenous generation of thrombin and plasmin. It occurs as a complication of a number of pathologic processes. It is suspected when the patient has an increased tendency to bleed. Therapeutic management includes controlling the initial cause, platelets and FFPs to replace lost plasma components, blood transfusion, IV heparin, and the nurse care management is to be aware of signs and symptoms, give IV infusions and blood transfusions, and administer heparin. Epistaxis is a nosebleed common in children caused by trauma, nose picking, mucosal inflammation due to allergies, and upper respiratory tract infections. There is no medical evaluation needed and usually stops with minimal pressure. Reoccurrence of nosebleeds can indicate an underlying disorder. As a nurse care management, we want to remain calm, reassure it that the bleeding will stop in less than 10 minutes with minimal pressure. Sit up and lean forward to control bleeding and apply pressure on the soft lower part of the nose with thumb and forefinger. Immunodeficiency disorders. There are many disorders that cause life-threatening alterations with the body's immune system. The most serious is severe combined immunodeficiency disease, and the most anxiety-producing is HIV infection and development of AIDS. HIV and AIDS. Pediatric patients that have AIDS are born to HIV-infected mothers or children who receive blood products. Horizontal transmission is transmitted through sexual contact or bodily fluids with visible blood, and perinatal transmission is transmitted by HIV-infected mothers and passes the infection to her infant. Clinical manifestation includes short stature, malnutrition, cardiomyopathy, neuropsychotic defects, development disabilities, defects in motor skills, communication, and behavioral functioning. Diagnostic evaluation and therapeutic management. There are a list of tests that can be performed. There is also a classification system made by the CDC that can be used for evaluation. Therapeutic management includes slowing the growth rate of the virus, preventing and treating infections, providing nutritional support, antiviral drugs, immunization, and nutritional interventions. Nursing care management includes promoting education, emphasis on safety of special medication, limit child activities to reduce risk of infection, counseling, screening, pain management, psychological concerns, financial support, and notifying the school and educate on precautions. The prognosis is the death rates and new AIDS cases have declined with the new combination antiviral therapy, but in contrast, adolescents and young adults are one of the fastest growing groups of the newly infected persons in the country. Severe combined immunodeficiency disease is a defect characterized by absence of both humoral and cell-mediated immunity. Susceptibility to infection early in life is the most common manifestation, and diagnosis is based on history of recurrent infections, family history, and lab findings. Therapeutic management includes stem cell transplantations, IVIG infusions, maintaining sterile environment, gene therapy, and then nursing care management is preventing infections, family support, and genetic counseling. Wiskott-Aldrich syndrome is a congenital X-linked recessive disorder characterized by three abnormalities. As the child grows, recurrent infections and eczema becomes more severe with less frequent bleeding. Repeated infections can cause chronic pulmonary disease, sinusitis, and otitis media. Medical treatment includes platelet transfusions to counteract bleeding, administration IVIG for passive immunity, administrating prophylactic antibiotics to control and prevent infections, and providing aggressive therapy for eczema. Nursing care management includes family patient support, physical care to control problems, control bleeding when it occurs, and prevention and control of infection. Technologic management of hematologic and immunologic disorders. Blood transfusion therapy is important, and we need to recognize any blood transfusion reactions. So, below are some guidelines applied to all transfusions. It is important as nurses that we become familiar with these. And then, apheresis is the removal of blood from a patient, separation of the blood into its components, retention of one or more of these components, and reinfusion of the remainder of the blood into the individual. And then last but not least, here's an NCLEX review question. Go ahead and press pause. And the correct answer is C. Thank you so much for listening.